My name is Nikolaos Diakos. I'm a cardiologist at the Texas Heart Institute, and I'm very happy today to be joined by Dr. Matthew Martinez. Dr. Martinez is a sports cardiology expert, a hypertrophic cardiomyopathy expert. He's also the director of the sports cardiology at Morristown Medical Center and cardiologist at major league teams such as New York Jets. Dr. Martinez was here today to give grand rounds at the Texas Heart Institute about risk assessment for the athletes for cardiovascular disease. Thank you, Dr. Martinez.
Thanks for having me.
So I would like to start with a more naive question. So people are thinking as sports medicine as someone that is gonna fix a fracture for one of the athletes or deal with like orthopedic problems that the athletes have. And they might say, oh, they are athletes, you know, they have good hearts. Like, so why do they need a cardiologist? So what is the role of sports cardiology in the modern medicine era?
It's a great question and a common question. So the role of the sports cardiologist, I think the part that we often talk about is for the elite level athlete, when they're handling a professional athlete or a high school collegiate athlete, someone who is trying to compete at an elite level. And in that group, you're looking to see if they have increased cardiovascular risk. Do they have symptoms? Do they have changes that have adaptations related to them being whatever athlete they are? Are they a swimmer? Are they a football player? And then we try and signal whether or not this is an abnormal finding or a pathologic finding. But the majority of the work actually is in everybody else. It's in encouraging exercise, talking about the type of exercise you participate in, whatever excites you, and then looking to see how we can continue to keep you exercising. Because as you get older, you might develop high blood pressure, you might develop elevated cholesterol, you might have a family history of coronary artery disease, or sometimes we find things incidentally, like a dilated aorta or a change in the heart muscle function, or maybe you had a heart attack, but you still want to exercise, or how can we get you to exercise after having an event? And that might be the most important role that we have.
Absolutely, absolutely. So, for those that they don't have access to a sports cardiologist, and as general cardiologists, we get those consults or those referrals for not elite athletes, but athletes are minor leagues or athletes or people that want to participate in sports at school. Tell us, based on your expertise, what should be the first couple of tests or the first screening that we can do to make sure that those people are not at risk when they're participating in sports?
Yeah. So first things first, right? A strong physical exam and a history are going to be important. You want to know who you're talking to, what type of athlete they are, what sport do they play, what level do they play, and then tell you about your family history, right? Are there some signals in there that may be a trigger for, I need additional testing? If they're symptomatic, then an ECG and an echo are absolutely the mainstay for how we're going to evaluate them. So if they come to you and say, I'm breathless, or I'm having arrhythmias or palpitations when I'm exercising, an ECG and an echo are absolutely the first test. And then I really love functional imaging. Some stress test, not an 85% and maximum exercise stress test, but a symptom-driven, symptom-limited exercise test. Maybe we can reproduce those symptoms. Maybe they're normal, but I can monitor you, often provide you with some peace of mind.
And me personally, being a heart failure cardiologist, I really like the exercise stress test because they answer you questions not only about the structure of the heart, the ischemia, but also what is the exercise capacity. And as you pointed out, sometimes as physicians, we don't have the time to physically participate in the stress test, and we get these results that they say, oh, they went 85% of their predicted heart rate, but they only went for 6 minutes. And then you ask the patient, so were you breathless at 6 minutes? Do you have symptoms? Say, no, I could go for another 5 minutes. So then you lose all this information that you lose if you don't push them to go further.
Absolutely. So well stated. So you know that cardiopulmonary exercise testing is a big part of heart failure. It should really be a big part of how we evaluate athletes too. And part of it is that you can monitor them. You can get a sense for whether or not they have a respiratory limitation. Do they have a cardiac limitation, or are they just deconditioned? And sometimes the athletes think they're in better shape than they are. Sometimes they've gone from being the best player in their county or their state, and now they enter a collegiate environment or Olympic environment, and all of a sudden everybody's just as good as they are, and they can't keep up.
Yes.
And this helps me sort out, maybe they're just deconditioned, and it isn't a limitation, they just need to be in better shape.
Absolutely. And you outlined really nice the fact that some of the findings that we have in athletes can be physiologic adaptations. And as cardiologists that we're not expert in sports medicine, we see those findings. We suspect that there may be physiologic adaptations. Can you give us some tricks how to tease it out that, this thick heart is not hypertrophic cardiomyopathy, and it is thickening and dilation of the heart because the person is really well conditioned?
Yeah, it's a great question. And what I would say to you is be comprehensive. So if you find thickness of the heart, you should be comprehensive. It should be HCM until proven otherwise in many scenarios. So it's very common, hypertrophic cardiomyopathy. So is high blood pressure. So are other diseases that we often miss. So what I would say is that it's an opportunity for you to engage additional imaging studies. I think after an abnormal echo and MRI is the next test. And I do think a functional study after that can be very helpful with looking to see what their blood pressure does, what's it at rest, and then looking for other potential things you can treat. So I would tell you to be comprehensive. I would tell you that there are lots of abnormal findings of the athlete, but first things first, let's make sure they're truly an athlete.
Yes.
Sometimes being a prior athlete doesn't mean that those changes are normal adaptations. And you're going to find thicker hearts, sometimes bigger hearts, dilated hearts. You might find a small increase in an aortic size, all of which could be normal. And what we don't want to do is tell folks not to exercise, because VO2 max is still the best predictor of health in virtually everything we do.
Yes. And since we're in the subject, HCM is, or hypertrophic cardiomyopathy, for those that are watching us and they don't like these acronyms, it's very common. It's the most common genetic cardiomyopathy is pretty much, if we want to put a title, it's an abnormal thickening of the heart muscle. And it is 1 every 500 individuals. So as cardiologists, we see them coming to our clinic. What does it mean for an athlete to have hypertrophic cardiomyopathy, and why is it important to diagnose it?
That's a great question, and absolutely common. It is under-recognized, so it's an opportunity for us all to think about making that diagnosis. And for an athlete, what's important is that 10 years ago, this was a almost automatic disqualification. So it was an important finding because it could be potentially career-ending. But it's also a common cause of sudden cardiac arrest in those under the age of 35. So it's important not only to make the diagnosis so we can better serve you, but because it's genetic, it can also have impact on the remainder of your family. So what's important is that there's never been a better time to be a hypertrophic cardiomyopathy patient. We have more therapies and more opportunities to treat them and evaluate them than we've ever had before, and exercise is the same. So having a conversation with an athlete who happens to have hypertrophic cardiomyopathy, or a patient who has hypertrophic cardiomyopathy who you're trying to exercise, this is an opportunity for us to improve their survival. So it is definitely an increased risk for sudden death, but also not exercising makes that risk even higher. So it's an opportunity, if you find it, to have a conversation with an expert and come up with what's safe for you.
And I want to take it from your sentence that you said before, that it used to be prohibitive to exercise. And during your talk, you nicely introduced the concept of shared decision making. And this is something that it's coming up in the modern era. Cardiology and medicine in general used to be paternalistic. So we were disqualifying people from doing things, or we were strongly advising people to do things. But nowadays it's more of a shared decision-making model. But still, the doctor has to be able to provide the information to the patient to be able to come up to a decision.
Absolutely.
So what is, in your case, in these elite athletes, that they are found to have some condition that maybe give them risk if they continue to exercise. What is the information that you like to give them, and how do you approach this shared decision making?
Yeah, I find that we underestimate the intuitiveness and the interest of the athlete in terms of their risk. They know that being an athlete helps them in terms of cardiovascular risk, but they're not bulletproof. So whether that's high blood pressure, heart artery disease, or hypertrophic cardiomyopathy. So what I approach this is not as an angle of, am I going to disqualify you or not, but rather an engaged conversation. You're not going to tell me I'm playing no matter what, and I'm not going to tell you you're not playing no matter what. So I try and gather the information, provide them what we think is an estimated risk, and then we come up with a plan for safety. And many of them say, I don't want to participate anymore. I'm okay. I know this is not going to be my livelihood. I don't really want to play as much as I thought I did after this conversation, and they walk away. And others say, I'm willing to take that small risk. I'm a football player. I understand risk. Or I'm a cyclist. I understand risk. They're often crashing, right? So they understand this process.
Yes.
So engaging them in that conversation. And then everybody's risk tolerance is different. What you're comfortable with taking a risk on, I may not be. And it's not my job to tell you what that risk tolerance should look like. So I provide them with information about what their risk might be, what their potential harm might be, making sure that their family is well aware of that, and then having a conversation with them about what I think is safe.
And does your job finish at this first visit, the initial visit,
Yeah.
or it involves kind of a longitudinal follow-up? And I know it's like a provocative question.
It's a great question. So what we often leave out of this discussion of shared decision-making is time. So it's not a once and done almost ever. It's always a diagnosis. Let's risk stratify you, which often includes testing we haven't done yet. That gives them some time to think about it. Then they come back with a little more information after the additional testing. We have another conversation. Then I usually involve other stakeholders, family members, potentially their teams or the institution that they're competing for. That's another point in time. And then even if we decide that it's okay to participate in a safe way, that everyone's in agreement with this, there's still going to be surveillance. You're going to come back, and I'm going to continue to risk stratify you. So you are stuck with me to have these conversations for a while, because it isn't a once and done, and often that risk can change.
Yes, and you said in the hypertrophic cardiomyopathy people, the fact that you diagnose them, you don't know if and when they're going to have an arrhythmia event, for example.
Absolutely.
So, and that, as you said, may change from year to year, from time to time.
Right, and as they progress, they may develop a symptom they hadn't had before, but I want to make sure that dialogue opportunity is open. So if I'm telling them, if you come back here and tell me something changed, you're disqualified, they're probably not going to tell me.
Yes.
So I really like this open line of communication where they are comfortable that if they tell me symptoms, if they tell me something has changed, that I can then further risk stratify them. Maybe we'll modify what our risk assessment ends up looking like, but we're going to look for a way of how rather than if. And I think that's what's changed the process for athletes. If they think you're going to automatically tell them no, then they stop talking to you. And that lack of communication is going to lead to harm.
And now we're at the point that one of your athletes is deciding that, I'm not going to participate in sports anymore. Does it mean that it shouldn't participate in any exercise or any activity? Because as cardiologists, we keep telling people, you have to get out of your chair and start exercising and moving and doing things that is going to increase your cardiovascular health and going to improve your cardiovascular health. So not being able to participate in competitive sports, does that equal not being able to participate in sports in general?
Yeah, absolutely not. And it's a really important discussion. So what I mentioned during the talk, and I often say, is that we're not deciding yes or no. We're deciding what and how and what that risk may look like. Because even if you can't play professional sports anymore, like most of us, and like most professional athletes, like all of them, there's a finite number of years that's going to occur. I still want you to exercise long term. We know that fitness, your VO2 max, your exercise capacity is the best predictor of outcomes in virtually everything that we can try and measure. So I don't want you to stop exercising. And it's an opportunity when you come back to see me every year for us to talk about what your diet look like. Are you hydrating? Are we managing your other risk factors? You know, high cholesterol, diabetes, high blood pressure. Are we managing those in addition to whatever that other inherited disease might be?
Thank you very much. That was great. Would like to thank you at the Texas Heart Institute for both this excellent grand round and this really informative interview.
Thank you. This was terrific.
Looking forward to see you again.
You too. Thank you.